Health security has become one of the most urgent challenges of our time. Unlike traditional threats such as war or terrorism, health threats are non-traditional. They cross borders and affect everyone. Since the Cold War, health has been securitized, meaning it is now treated as a matter of nation and global security. The COVID-19 pandemic is the clearest example, reminding us how fragile our system can be. In this video, we will explore the concept of health security, its history, major drive, case study, and the challenges it poses for the world today. Health security can be understood in different ways. From a human security perspective, it's focused on protecting individual well-being. From a national security perspective, it safeguards population and state sovereignty. And from a global security perspective, it addresses cross-border threats like pandemic. At its core, two questions drive the debate: who are we protecting and what we are protecting them for? With the securitization theory, we see how health secrets often justify extraordinary measures such as lockdown or emergency power.
Disease has always shaped security. The Black Death devastated Europe in the 14th century, reshaping economies and societies. Quarantine and sanitary measures were early form of disease control, but today's world is far more interconnected. With globalization, outbreaks spread faster, making diseases not just a medical issue but also a security threat with global consequences. Modern health threats are driven by 6 key factors. First, human demographics and behavior, such as urban crowding. Second, technology and industry, including mass food production. Third, economic development and land use, like deforestation. Fourth, international level travel and trade, which spread disease quickly. Fifth, microbial adaptation and resistance as bacteria evolve. Sixth, the breakdown of public health systems. Examples such as SARS, Ebola, and COVID-19 illustrate how these factors combined with globalization intensify health insecurity.
The first case study is the Ebola outbreak in West Africa. It began in Guinea in late 2013 and spread quickly to Liberia and Sierra Leone. In total, there were about 28,600 reported cases and more than 11,300 deaths. The health system in this country were extremely weak, with very few doctors and limited facility. Communities often distrusted the government and health workers, which made the situation worse. In September 2014, the United Nations Security Council even declared Ebola a threat to international peace and security. This showed clearly that Ebola was more than a health crisis. It was a security issue. The Ebola outbreak had very serious security impacts. Health system collapsed, leaving people vulnerable not only to Ebola but also to other diseases like malaria. The World Bank estimated that Guinea, Liberia, and Sierra Leone lose more than $2.2 billion in GDP. There was also widespread fear, social unrest, and even attacks on health workers. Because of the instability, international intervention was required. The United Nations and the United Kingdom deployed military forces to help both in treatment center and provide logistical support. This case shows how fragile state can become destabilized by health crisis. The second case study is COVID-19, which began in Wuhan, China in late 2019 and then spread worldwide. Unlike Ebola, which remained mostly regional, COVID-19 became a true global pandemic. By 2023, there were more than 760 million reported cases and nearly 7 million deaths. Economically, it triggered the sharpest global recession since the Great Depression, with the world economy shrinking by more than 3% in 2020. Beyond health, COVID-19 also caused an infodemic, the spread of misinformation, and it revealed deep inequalities in vaccine access, which richer countries securing doses before poorer nations. COVID-19 created many security challenges. First, it deepened geopolitical tension, especially between the United States and China, with accusation over the origins of the virus and vaccine politics. Second, economies collapsed, such as tourism, trade, and jobs, were heavily affected. Third, there were even cyber attacks on hospitals, showing how health systems are linked to digital security. Finally, vaccine distribution was very unequal, with developing countries left behind. This case demonstrates that even advanced states with strong systems are vulnerable, and pandemics can reshape global politics, economy, and society.
States and institutions respond through multiple strategies. These include lockdowns, quarantines, and mandates, preparedness exercises, and interagency coordination, rapid medical research such as mRNA vaccines, and stockpiling critical supplies like PPE. Global systems like the WHO and the Global Health Security Agenda strengthen surveillance and cooperation. Yet, despite these measures, challenges remain. Health securitization creates ethical dilemmas. Some diseases get more attention than poverty or hunger. Vaccine nationalism deepens inequality between rich and poor countries. States may overreach by enforcing surveillance or forced quarantines. Funding gaps, weak health systems, and health worker burnout also reveal systematic vulnerabilities. The tension between protecting public safety and upholding human rights remains a central challenge.
Often overlooked, mental health is a vital part of health security. Pandemics create stress, anxiety, and depression, while lockdowns and job losses leave long-term psychological scars. Including mental health in emergency plans is essential for true resilience. In conclusion, health security is both a national and global concern. It demands preparedness, equity, and international solidarity.